Welcome, everybody. And after that last session, we're going to change gears entirely and focus on the session that's called Demystifying the Vulnerable Plaque. I also want to remind you to submit questions to our panel through the dedicated Q&A link, and I'll be reminding you of that as we go through. And I'm really joined by an outstanding panel today. I'll actually have the panel introduce themselves, but we have a fantastic group of people, and maybe Azeem, starting with you.
Hi, I'm Azeem from New York. Great to see you all again.
Margaret.
New York, Claudia.
Maybe
nice to join the session.
And then Joost.
Joost Daemen from Rotterdam. Welcome, everybody.
And Valeria.
Hello, everyone. Valeria Paradies from Rotterdam.
So it's a phenomenal group of people, and we have 3 focus presentations that will take us from detection to risk assessment to treatment of vulnerable plaques. And we begin with Joost, who will open our understanding of how we find these vulnerable plaques in the first place with a variety of imaging modalities.
Thank you, Ajay, for the introduction. So within the next 8 minutes, I'll talk a little bit about the types of the vulnerable plaques and how we may encounter them in our routine clinical practice. These are my disclosures. So the term vulnerable plaque, it's actually nice to reflect a little bit, was historically actually proposed by Jim Muller in the late 80s. But today, high-risk plaque is potentially a more contemporary term to indicate the 3 precursors of all 3 major substrates that have been identified to incite luminal thrombosis. And these 3 plaque types encapture the rupture-prone plaque, which is the thin cap fibroadenoma, probably the most well-known type of plaque, the erosion-prone plaque, and the eruption-prone calcific nodule, which is less frequent but also very important to be able to recognize. In the past decades, the insights into how these plaques develop and finally potentially rupture has changed a little bit. And one of the most striking differences is the interest in the endothelial erosions, which initially were thought to be responsible for about 1 in 5 cases of ACS. But now it appears that they may account for even more than 1 out of 3 cases. And that could be an epidemiological phenomenon, but it could also have something to do with the fact that we're simply more vigilant on identifying and detecting acute coronary syndrome by using high sensitive troponins, but also by the fact that we're simply using more imaging in cases in which the culprit is potentially not that clear initially. Moreover, the way we look at plaques has changed over the past decades, simply because the progression of disease and the types in which these plaque rupture has been identified as the multifactorial problem because of morphological features versus biological activity, dynamic changes that may occur in plaque composition, the importance of plaque burden as a volumetric entity, the issue of inflammation, both within the plaque as from a patient perspective, healing mechanisms, flow patterns, which have got a lot of attention in the past decades with shear thrust patterns and so on, the properties of fluid phase and blood, and the amount of myocardium at risk subtended to a lesion. So when we look into each of the individual types of plaque, we'll start with the most frequent one and probably the most well-known one, which is the thin cap fibroadenoma, or simply called TIGFA, which is characterized, as all of you know, by a large necrotic core, large lipid pool, and a thin fibrous cap. On pathological data, identified as a cap which has a thickness less than 65 millimeters. Sparse smooth muscle cells, and there may be microcalcifications and the accumulation of activated macrophages. The identification, though, of the TIGFA is potentially easy for somebody who is well familiar with the use of intravascular imaging and with OCT in particular, but it has been shown that this is not readily identifiable by potentially less well trained physicians. And that's where a lot of technologies these days come in very handy. One is the infrared, the near-infrared spectroscopy. Second is combined imaging techniques with OCT and NIRS, but also, and I mean, that's very contemporary, not a single talk you will see these days without AI features. The way that current software applications allow you to automatically identify lipidic plaques, like for instance, the OCT Plus software of Pulse Medical, which will allow you to automatically identify lipids based on AI algorithms. But also somewhat more accessible is the newest version of the Ultrasound software of Abbott, which now not only gives you an automatic quantification of the amount of calcium you may find within each of the individual cross sections, but now you also get an appreciation of the identified lipids, also with a patented AI algorithm, which simply provides you with a blue line on the caps of plaques that have been identified as lipidic. So I think this is a great way to help us to identify lipids in a contemporary practice, even by those physicians who are perhaps a bit less well trained. Near-infrared spectroscopy is obviously something that most of you are aware of, a technology that allows you to identify lipid using near-infrared light with a high diagnostic accuracy, validated in a broad spectrum of pathological disease specimens. And as we've learned from the LRP registry, as well as the Prospect 2 trial, if you have a plaque with a lipid core burden index above 400, or within Prospect 2, a LCBI above 324, the likelihood that these patients are at risk of future adverse cardio events is at least 4 times as high as according to the LRP study, and almost 7 times as high as where we refer to the Prospect study. So this just identifies or illustrates that the identification of vulnerable plaques with near-infrared spectroscopy is a great tool to automatically identify those at risk for future adverse cardiovascular events. Looking into more contemporary technologies, and obviously there's a plethora of new technologies that help us to identify vulnerable plaques. This is just one I wanted to briefly highlight because this is a technology very close to my heart as it is currently being developed within the Erasmus Medical Center. It's called intravascular photoacoustic, which actually uses photoacoustic imaging to get an even better appreciation of the amount of lipids in a particular plaque. With the key difference to NIRS that it really gives you both the ability to quantify the amount of lipid per each individual cross-section, but also gives you a identification of the depth and the localization of the lipids, which is not that available within the NIRS imaging. So this technology, we actually did the first pig experiment this morning, is very promising, and we hope to do the first in humans somewhat later this year. So stay tuned on this one. The erosion-prone plaque, as mentioned, a plaque that has received somewhat more attention in the last decade, and it's really interesting and important to be able to recognize these plaques as they may be the cause of ACS in a lot of cases in which the culprit is not that readily identifiable on the plane angiography. So the erosion-prone plaque is defined by thrombus formation in an area of endothelial damage or denudation adjacent to an atherosclerotic plaque without signs of disruption of the endothelial border. And what is interesting and what a lot of people probably don't know is that these plaques usually lack typical lipid or necrotic core. And in contrast, they are usually located in areas rich in smooth muscle cells and extracellular matrix. So this is clearly different as compared to the conventional TIGFA. They are the most frequent precursor is, as mentioned, the underlying fibrous plaque, and they're often eccentric and negatively remodeled. Moreover, they're infrequently calcified. So this is just to show you the key features of the erosion-prone plaque that is clearly different from the conventional TIGFA. Finally, and this is the nasty animal amongst the 3 different types of high-risk plaque, is the calcific nodule. With the focus on intravascular imaging and helping us to guide PCI, these nodules have received a lot of attention in the past decade. But what is important to realize that they yet still account for about 2 to 8% of ACS cases. And not surprisingly, older patients and patients with chronic kidney disease, as you know, this is likely the most important precursor of calcific disease. Moreover, they are preferentially located in the proximal to mid-right coronary and within the left main bifurcation. And with that in mind, I think it's important to realize that this, to me, is also one of the drivers to use intravascular imaging, specifically in these proximal to mid segments, where you may be able to find these nodules which clearly mandate different types of lesion preparation as compared to a conventional erosion or a soft TIGFA. Eruptive calcific nodules, as mentioned, a nasty animal because these lesions and in particular PCI of these plaques is associated with significantly higher risks of future MACE as compared to PCI of soft plaques, erosions, or plaque ruptures. So this is just an example of 2 registries or 2 dedicated studies looking into this phenomenon. So be aware, calcific nodules, important to realize, to identify, and to treat accordingly. So where do plaques develop? High-risk plaques in particular, typically, as mentioned already, in inner curvature of arteries or the outer ways of bifurcations, and particularly in the proximal segments of the right, the LAD, and within the circumflex, which have been identified as regions that are particularly exposed to low endothelial shear stress, as we have learned from a lot of work also performed within the groups of Atlanta and within the Thorax Center, in areas where, as you look into the endothelial shear stress, is the lowest, and those are the areas which are most vulnerable to plaque progression. Does size matter? This is a slide I want to show you because I think this is one of the things that is really readily available in all the imaging cases you do within your present cath lab, and also showing you the clear difference between IVUS and OCT to guide your PCI. Whereas OCT gives you a higher resolution, IVUS gives you the visualization, not just of the lumen, but also of the vessel border, which allows you to assess the size of the plaque. And this is important because if you would just look at the lumen, you will see that this vessel is about 3.0 in terms of residual lumen diameter, area of 6.5. But if you would delineate the vessel, you would see a vessel area of 22, which would represent a plaque burden of 70%. And I really would like to encourage you to remember this figure and this number of 70%. But within the prospect trial, the IVUS-derived plaque burden with a cutoff of 70% proved to be the strongest predictor of MACE at a median follow-up of 3 years, with a hazard ratio of over 5 at the lesion level analysis. So very importantly. Conversely, if you look in prospect 2, and what we've learned from that is that plaques with a plaque burden below 55% basically never result in acute coronary syndrome. So these figures are important and are readily available now in routine practice. And also here, AI comes in handy because in the past, you'll recall you had to draw several circles in each of the individual cross sections to get your plaque burden. Well, that is actually something that at this day and age belongs to the past, because with the newest version of imaging software here, like just as an example, the IVUS software, the AI tools give you automatic lumen and media delineation immediately and instantaneously after the pullback, giving you the plaque burden at each of the individual cross sections, helping you to identify first high-risk plaque features, but also to help you identify segments where you particularly do not want to land your stent. A final word on CTA. As you know, this is a technology that has been broadly adopted these days, specifically for screening purposes, also according to guideline recommendations in low to intermediate risk patients. And where initially we only looked at calcium scores and grayscale images, now with the advances of AI and many different vendors that allow you now to do also plaque characterization completely or semi-automatically based on the CT images, you get an impression of positive remodeling, low attenuation plaque, napkin ring signs, and spotty calcifications, which all have been linked in dedicated registries and studies like PROMISE and SCOTHART to future risk of MACE on a patient level. And the patient level is important because these studies have not evolved into a phase in which the particular high-risk features are really linked to specific lesion-specific endpoints. But I think this is just a matter of time and will follow hopefully in the near future. So with that, I would like to propose several discussion items. First, imaging improves clearly the risk stratification and can detect or help us to monitor preclinical disease and progression. I also would like to highlight that, at least in my opinion, the identification of high-risk plaque is not a binary entity. There are a lot of items that you need to factor in terms of identification of plaque risk. And there are no widely established binary treatment cutoffs. And that's something we will touch upon also later within the session. Finally, it goes without saying that the AI features that are currently becoming more widely available really allow us to greatly facilitate the identification of high-risk plaque features. With that, I would like to conclude. Thank you, and open up the presentation for discussion.
Yost, thanks so much. That was a great overview. I mean, that could have been a massive, massive topic, and then you went through everything really nicely and succinctly. I think because we're running late, what we'll do is move on to the next talk, and Valeria is going to talk to us a little bit about, how risky are these vulnerable plaques. We actually had a comment in the questions that were sent in, so thanks. Keep sending those in about specifically that question, and another one that was touching on it. So I'm sure she's going to answer those things. And let's go to her talk, and then we'll keep going, and then have some time for discussion at the end.
Thank you so much, Ajay. So it's a pleasure for me to discuss now and move on from what Joost presented, how to detect a vulnerable plaque. And now let's have a look at the risk. But before doing that, I want to take just one step back and talk about the pathology, because if you want to look at natural history of plaque progression, then we have to start from pathology. And we all know that everything starts, so the early stages of atherosclerosis started with adaptive intimal thickening. So when we have accumulation of macrophages, this could lead to fatty streak, and there's still potential for regression in the fatty streak. But we can also have accumulation of an extracellular lipid pool, smooth muscle cell proteoglycans, and that's when we have a pathological intimal thickening. The next stage of progression of vulnerable plaque is the infiltration of macrophages. This is a very crucial step, which leads to the early stages of fibroateroma. The macrophages will activate also inflammation, and that's something we will discuss further during my presentation. At the level of fibroateroma, then we will have processes of necrosis, apoptosis, hemorrhage. Everything will lead to the thin cap fibroateroma, what we just saw from Joost's presentation. We learn how to identify it at the intravascular imaging. But what can happen is that when we have accumulation, further accumulation of macrophages, regression of phagocytosis in combination with flow disturbances at local level, we might have indeed a plaque rupture. This might cause acute coronary syndrome event, but also accelerated plaque progression, or just, let's say, cool down and go into a healing process. We also learned that thin cap fibroateroma has been historically associated to 75% of acute coronary syndrome presentation. And we also have 25% more or less associated to eruptive calcific nodule or to erosion. So all these precursors are important. It's important to know that they exist, and that they might lead to an event, an acute coronary syndrome event. But there are also some risk factors associated to the patient and also to the lesion level. So indeed, what we discussed, the extension of plaque burden, but also inflammation. This is a very important concept emerging recently, both at patient level and also at the lesion level. Impaired healing, we refer to the activation of a prothrombotic milieu. We also know endothelial shear stress plays an important role at local level, and the amount of myocardium at risk. What happens in trials, we learn from the Prospect trial, where acute coronary syndrome patients, 700 acute coronary syndrome patients underwent IVUS investigation, and that in non-culprit lesions, and we saw that indeed lesions presenting all morphological high-risk features were associated to an 11-fold higher risk of MACE at almost 4 years of follow-up. We learned from the combined trial in diabetic patients that despite these lesions being not responsible for ischemia, the presence of a thin cap fibroateroma was associated with a 5-fold higher rate of MACE. And we also learned from the Prospect 2 trial that the presence of a high lipid cord burden index, as well as a high plaque burden, more than 70%, was associated with a very high risk of MACE at 4-year follow-up. But when we put all these studies together, what we realize indeed that the relative risk associated to each lesion might be high, but the absolute risk associated to each lesion is pretty low and was mainly driven in these studies by late revascularization, not by heart endpoint. Another very important point for discussion is the predicted positive values of vulnerable plaque in these natural history studies, which stays anyhow below 20%. So why is that? Why are we not able to identify, or let's say why this predicted positive value of vulnerable plaque remains so low? Of course, it's related to the methodology. We learned from Joost's presentation that IVUS might be less accurate in detecting plaque characteristics, but it also pays back in other features. These trials looking at natural history did not assess plaque with serial evaluation. Of course, we learned that plaque evolves. So if we just have a snapshot of the lesion that we don't know what's going to happen in a few months, we also learned that thin cap fibroateroma does not necessarily cause acute coronary syndrome, but also go into a process of healing. And sometimes acute coronary syndrome is associated with erosion of calcified nodule, and also the role of inflammation, because we also have to acknowledge that inflammation plays a very important role. So talking about a serial assessment at intravascular imaging, this study investigating STEMI patients treated with high-intensity statin showed indeed that in 2/3 of thin cap fibroateroma, we had stabilization of the plaque, and also we learned an increase in minimum cap thickness for both thin cap fibroateroma and thick cap fibroateroma. And this is something new, a new frontier, a NIRF to identify indeed inflammation. So the near infrared fluorescence is now at a research level, but the point is to address it, to investigate what's the level of inflammation at a plaque. And my last question is also bridging the Margaret's presentation about preventive PCI of vulnerable plaques. This is an overview of all trials which have investigated the role of PCI of vulnerable plaques, and probably the striking results of PREVENT trial deserve some discussion. We learned from this trial that 1,600 patients, stable patients with non-flow limiting intermediate lesions, when randomized to optimal medical therapy or to preventive PCI, they show a benefit in terms of primary endpoint at 2 years follow-up when PCI was performed. Some consideration for this trial: the benefit was primarily driven by a reduction of late revascularization. So again, this is what the primary endpoints are mainly driven by. Number needed to treat to prevent one primary endpoint event was 45, particularly high. And when we look specifically at cardiac death or target vessel MI, was even higher, was 87.7. Thank you for the attention. I will get back to Ajay for discussion.
Perfect. Thanks so much, Valeria. And I think we've gotten back on time with those two complimentary presentations. We actually have a lot of interest. There's a bunch of questions in the Q&A as well. And I think what you highlighted at the end is a good place to start, in the sense that when we look at the actual events that some of this detection can prevent, oftentimes, even in trials like Prospect, the MACE events are driven by not large MIs, not death events and that sort of thing, but even just repeat revascularization. And so maybe if we start there in terms of this fundamental question of how risky this is, and Azeem, I'll start with you. If you sort of, if you knew you had a plaque that was at risk of some kind, is there enough to be actionable about right now, or what sort of things do you think about in terms of the modality that was testing it, and how you would follow people, et cetera?
Yeah, absolutely, Ajay. I mean, vulnerable plaque has been this really hidden thing we've been trying to figure out for years. How do we prevent future events in our patients? And if we can detect it, how do we treat it? Because honestly, I think many of us, even those of us who put stents in, don't want more stents. Don't want stents, unnecessary stents in our bodies. Which was the whole idea behind Prospect initially, was, could we put a scaffold in that wouldn't be there permanently, right? So, I mean, for me personally, I think the data is promising that we're going in the right direction to be able to detect vulnerable plaque. I'm still, in my own mind, not convinced that the best way to treat it is a stent. I think, there's also a place for aggressive medical therapy and LDL reduction with new drugs. And I'd love to see in the future, non-permanent therapies to address them. So whether that be a drug-coated balloon or potentially newer scaffolds that are being tested right now in Europe that have addressed many of the concerns we had with first-generation scaffolds.
One thing that's super interesting is that, especially with data like Vesalius CV, which was looking at treatment that's outside the paradigm that we currently exist in, which is you wait for an event and then you intensify therapy, which doesn't make sense to a lot of people. Just inherently, you don't feel like doing that. You want to treat earlier. In that trial, just by being at risk and treating aggressively, you could reduce events. And so I think many of us are now looking at CT or other ways of detection of plaque as a marker and a way to tell patients to intensify their therapies before they have an event. And where there was a question, Joost, for you, maybe, which imaging modality is going to give us the most actionable information? Maybe answer it practically as well as idealistically in terms of these modalities.
Yeah, I think this to me is the most critical point, and also as touched upon by Valeria. I mean, if you look in absolute numbers, Prospect 2, the numbers with the high LCBI, patients had a non-Coulthard level MACE of 3.5% at 4 years. So in absolute numbers, those numbers are really small. But I think we make it better in thinking a little bit out of the box and out of the binary entity in terms of best imaging modality of best cutoff, because I don't think we're there yet by identifying the optimal way to identify the vulnerable plaque. Its volume, its cap thickness, its lipid content, its inflammation, its shear stress. So there are a lot of factors at stake that I think play a role. And then there's obviously the anatomical parameters like plaque burden and minimal lumen area. So I think at the end, I think we need to learn how to take them all into account to make a proper assessment on which plaques may warrant treatment. And it's very likely that the vast majority will potentially have the greatest benefit from optimal anti-lipidic therapy and anti-inflammatory therapy.
Yeah, I think, those are really key points. And to be perfectly honest with you, it's almost as if it's going to be very hard to find something that has a specificity to then say, if you see this, then you're going to have an event to then treat, which is, I think, Azeem's hesitancy with regards to these mechanical treatments for it. And it may be more pharmacologics, but it's still important to detect this vulnerability, because I think that if you see something and you know that the risk is higher for a patient, that's probably a very powerful motivating factor. I know, Valeria, any final comments? I know you had proposed a couple questions. I want to give you an opportunity before we go to Margaret's talk, which is about the therapeutics and potentially what therapies could exist without metal even as well. But so, Valeria, any thoughts?
Yeah, I mean, these are all valid points you made, and I agree with you. I echo what you said. These events, sometimes the first event for a patient can be catastrophic. So detecting vulnerable plaque upfront before the patient experiences an event can really be life-changing. For going into therapies, of course, we want to be less invasive as possible, but we also want to ensure that the patient get the best therapy, and that could be at a systemic level. So we learn in the recent years that there are a lot of pharmacological options for treating vulnerable plaques, which indeed actually showed also at intravascular imaging analysis that might reduce the plaque volume. But also at local level, we might think about something which is not permanent. So all the discussion now about drug coating balloon or bioresorbable scaffold, I think in the context of vulnerable plaque, these options really might make a big difference.
No, I think those are great points. And to the questions in the audience, one was asked specifically about technology, a specific technology in their vulnerable plaque detection. I think right now the data's out on all of these, and that's one of the reasons why some of the CT companies are actually doing prospective studies to assess their algorithms in those ways. And the same thing would hold true with invasively oriented detection therapies for detection techniques for vulnerable plaque. I think from the treatment standpoint, there was a question from the audience also about at what point does your risk become sufficient so as to merit a treatment with a mechanical strategy as opposed to just medical therapy. And again, the data is still out on that too, especially in the era of contemporary medical therapy. But I think that's one of the reasons why all of us are so interested in this topic. It keeps coming back because ultimately, as cardiologists, we all probably went into the field to try to prevent MI events, and that's why this resonates with us. Because if you could detect something that was going to cause that event, of course we'd want to prevent it in some way. So maybe Margaret, if you had any thoughts, or before we segue to your talk directly about potential ways to treat it. Or do you want?
Yeah, I think it leads nicely actually just straight into the talk, I think, and we can have a good discussion at the end.
Perfect. So Margaret's talk is on specifically what we've been talking about, DCBs and scaffolds. And so take it away.
Okay, so as we've been discussing with all the advanced imaging technologies, both non-invasively and invasively, it's now possible for us to determine in a lot of patients whether the plaque that they have is stable, whether it's vulnerable, or indeed whether it's ruptured or eroded. And this has led to, as we've been discussing, this thinking about whether we can pacify vulnerable plaque before it causes future ischemic events. And there's been some discussion about whether this could be done with PCI. And in the nature of this talk in particular, I'm going to focus on what evidence or data do we have that maybe there's promise there with DCB or BVS. So let's start with talking about DCB. So there's this nice little study from the Netherlands published a couple of years ago called WLRP. So what you see here is an angiogram on the top left, where there's a very innocuous looking plaque. And then on the right, that's an image from an IVUS NIRS catheter. And in the bottom left, you see this measure we've been discussing, max LCBI, so maximum lipid core burden index. And what it measures with over a 4 millimeter segment, what's the maximum amount of lipid, and it's quantified. And as we've been discussing, the thresholds for that have previously been 400, and now from more recent data, 325 for us to think of this as a lipid-rich plaque. So in this small study, it was 18 patients who'd presented with an ACS. They'd had successful PCI to their culprit lesion. They then went on to 3-vessel IVUS NIRS performed to look for these lipid-rich plaques. I said the threshold of 325. You see that on the left-hand side, you'll see that the baseline maximum LCBI was 397. The patients then had these lesions treated with a paclitaxel coated balloon and then returned 9 months later and had repeat angiography and repeat NIRS. And you see that the max LCBI had fallen to 211 and this was statistically significant even in the small number of patients. What's also interesting, though, is if you look at the IVUS parameters of plaque burden and MLA, there was no change in those. So interesting kind of hypothesis generating data about the possibility of DCBs being potentially therapeutic in these lesions. So just to mention a couple of other ongoing trials in this space to watch out for. So this is Passivate CAP, the Passivate CAP trial from China. This is the study design paper was published last year. Again, same population, patients with ACS. They identify non-flow limiting, non-culprit lesions, this time using OCT. You'll see the parameters for entry are fibrous cap thickness of less than 75, and two of the following, an MLA of less than 3.5, a lipid core angle of greater than 180, or the presence of macrophages. If the patient was identified of having a vulnerable plaque, then randomized to paclitaxel versus medical therapy. And then the primary endpoint for this trial, interestingly, is MLA at 1 year. And we can discuss some of this later in terms of imaging modalities and endpoints for some of these therapeutic trials. Two other trials to watch out for. I'll start on the right, DELETE LRP, another study from the Netherlands group. So again, all these trials recruit the same patient population, ACS, non-culprit, non-flow limiting lesions. This is a follow-on trial with IVUS NIRS, with the LRP identified again with the LCBI of greater than 325. 400 patients will have IVUS NIRS. They estimate 50% of these will be identified to have a lipid-rich plaque, go on to randomize them to DCB versus medical therapy. And just like the data I showed you earlier, the primary endpoint is going to be mean difference in LCBI from baseline to 9 months. Bigger trial from China, same patient population, but this time using IVUS or OCT. And you see here the vulnerable plaque definition. And this is interesting because as we've been discussing, there's multiple ways to define this depending on what imaging modality you use. So plaque burden more than 65, MLA less than 3.5, fibrous cap thickness of less than 75, and a lipid arc of greater than 180. 1,869 patients, again randomized DCB versus medical therapy. And in this bigger trial, looking for a clinical endpoint of TLF at 24 months. So these two trials both anticipated to be finished by the end of 2027, early 2028. So I'm going to slightly jump outside of my remit just because I think it's interesting to delve into DCBs and ACS if I kind of have the luxury of extending the topic of my talk, and just quickly run through a little bit of the data in this space, because as I started to read into this more, I was kind of interested to see. So this is the Revelation trial. STEMI patients randomized to DCB versus DES. It was a single center, 120 patients. You had to have less than 50% residual stenosis after your pre-dilatation. And there was 18% crossover from DCB to DES. Young, really minimally comorbid, lower risk STEMI type population. Primary endpoint was FFR at 9 months. So the patients all came back at 9 months, had angiography and FFR, and you see no difference in this small study, no difference in late lumen loss. And then they recently published the clinical endpoints, which obviously not powered for in such a small trial. Interestingly, reflecting the low risk population, very low number of clinical events and no difference between the two groups. Going on to look at NSTEMI. So this was a PEPCAD study. NSTEMI, DCB versus stents, now historical, nearly 10 years old, only 200 patients, 56% bare metal stents, kind of reflecting the historical nature of it, again with a 15% crossover from DCB to stenting, and they reported no difference in TLF at 9 months. But as I say, obviously weakened by the control arm of the bare metal stents. Basket Small 2, which was really the pivotal small vessel study for DCB. They did a pre-specified sub-study looking at ACS versus stable angina. 214 of the 750 had an ACS. And they showed sustained efficacy in both ACS and stable angina out of 3 years without any significant interaction between the treatment and the presentation. More recently, the Japanese PCI registry did a retrospective analysis, propensity score matched to patients, very kind of low risk, simple ACS group, very simple single culprit lesions. They had to have successful uncomplicated treatment. So no hybrid, no bailout allowed. They were all excluded. 5,000 patients though, and showed at 1 year, no difference in clinical outcomes in this kind of lower risk ACS population. There's been a meta-analysis you see here, interestingly, including 11 STEMI trials and 2 NSTEMI trials, no difference in outcome. but obviously a collection of fairly small number trials with some degree of heterogeneity. Wanted to quickly just mention the two big RCTs in the DCB de novo space recently. So REC Cage 3, as we all know, DCB didn't achieve non-inferiority against DES, but did in the small vessel cohort. And interestingly, there's very high prevalence, over 50% of ACS in this study. But when you look at the ACS subgroup on the forest plot, interestingly, the DES seemed to be favourable in the ACS population. This was obviously hypothesis generating, and the actual formal sub-study sub-analysis is awaited to be published. Same thing with solutions. So in a solutions, a third of the patients have an ACS. As we all know, they achieved non-inferiority for DCB versus DES. But interestingly, in the presentation at TCT last year, in the forest plot of the subgroups, they don't include ACS. But I do understand that a sub-analysis and subgroup paper is currently being prepared. So lastly, just briefly to discuss what we know about BVS in this space. So obviously the promise of BVS was to prevent recoil, but without the permanent implant of a stent. And this would facilitate a lifetime of future revascularization options for patients. It would allow vessel remodeling, recovery of vasomotion and conformability, and reduce the late events that we now all know accrue in patients that have DES. So the biggest program was the Absorb program. This is the patient level pooled analysis, and kind of quite interesting. So 5 studies of BVS versus EES, nearly 6,000 patients. Again, this data is now historical for 10 years old. Over a third of the patients in the program were ACS. And as we all know, the device was designed to dissolve over 3 years. And we saw this excess event rate of TLF and device thrombosis in the early years. Interestingly, we see that levels off, and that risk seems to disappear once we get out to 3 or 5 years. At the same time, historically, was this other study, the IATA study, conducted in the Netherlands. This was an all-comers trial, again, about the same time period, 1,845 patients, same thing, BVS versus EES. Over half were ACS patients. Found no significant difference in target vessel failure at 2 years, but just as in the Absorb program, saw this excess event rate of target vessel MI, target lesion revasc, driven by device thrombosis issues. Just interestingly, when they looked at the time phenomenon that we just saw in Absorb, when they looked at 3 to 4 years, they still saw this signal of excess events in the BVS group, but once they got to 4 to 5 years, it was lost and there was no excess events. So as we briefly discussed, the BVS is on its way back with the new Evolve platform. So the Evolve version of Absorb is Eversorb. What they've managed to do is reduce the strut thickness and also improve the radial strength of the device. And then there's a magnesium scaffold system, Freesolve. And there's as we mentioned earlier, there's a biomag program of studies that started and progressing in Europe at the present time. So just to finish, do we have any data for BVS for vulnerable plaque? So this was the RCT that was embedded in Prospect 2. So just to remind you, Prospect 2, 900 patients, STEMIs and NSTEMIs. After you treated the culprit lesion, free vessel IVUS NIRS was performed. Non-culprit lesions were identified that had negative IFR or FFR. They had a percent diameter stenosis less than 70 and a plaque burden over 65, and then get randomized to BVS or medical therapy for these lesions. So 182 patients. Primary endpoint was MLE at 24 months, secondary endpoint of TLF at 24 months. So what they found, as you would expect having implanted a scaffold, was that the MLE was significantly higher in the BVS group than the medical therapy group. There was no difference in events at 20 or in TLF at 24 months follow-up. So in PREVENT, so RCT conducted in Asia Pacific between 2015 and 2021, 1,600 patients, actually interestingly, predominantly stable angina patients. Then unculprit lesions, an FFR of more than 0.8, and then you could use multiple modalities to call them vulnerable plaques, and we can elaborate on this. So as you'll see, most of the patients were identified because they had an MLE of less than 4, or a plaque burden of more than 70%. Some patients with an LCBI, some patients with TICFA and OCT, randomized to PCI versus medical therapy. The intention in this trial was these patients to be treated with BVS, with Absorb. After a third of the patients were randomized, Absorb was removed from the market because of the excess event rates associated with the device, and the rest of the patients got Xience. And this primary endpoint of cardiovascular death, target SLMI, ischemia-driven TVR, and hospitalization with angina. And as we saw earlier on, there was a benefit, apparent benefit of preventive PCI, but as we discussed, with a high number needed to treat to accrue that benefit. So just following on from that, and just to stimulate our discussion, I saw this patient in the office yesterday, and this is what the referrer had sent to me. So they sent the CT scan you see here. So the patient's kind of got mild to moderate disease in all three vessels. But the referrer says the patient's symptomatic. They've got identified moderate disease in LAD. In light of the PREVENT trial that has demonstrated that patients have with non-calcified moderate stenosis and high-risk features benefit from stenting. So basically, this referrer was referring this patient on to me because of their interpretation of the PREVENT trial, suggesting that we should be doing PCI in these patients. So interestingly, that has penetrated into the general cardiology community environment in the New York space. So in conclusion and for discussion, there's preliminary evidence that PCB may reduce lipid core, with ongoing studies to further investigate this. Whether this translates into a meaningful clinical impact and outcomes needs to be further investigated. There's some small randomized trial registries and a meta-analysis that suggests DCB may be non-inferior to DES and ACS, but there's some conflicting data. ACS sub-studies of the large DCB de novo trials are awaited and will be interesting, and we need some larger DCB for ACS trials to really have robust evidence. I think the role of BVF in the treatment of vulnerable plaque and ACS remains uncertain at this time. Thanks.
Margaret, that was great. I think, was it Monday when Margaret and I talked, and Margaret was like, I don't know what I'm going to talk about. And then you did this, which is like phenomenal. So, and with that patient story too, which I'm completely at a loss to explain.
It's quite amazing. It was so coincidental, right?
Yeah. I don't think that that's pervasive, but anything will happen anywhere. And frankly, just looking at the number of questions in the chat, it shows you this is a very, very hot button topic. So maybe one question I'll ask maybe everybody to chime in on. We really have like 2 minutes left. What would a practice-changing trial in vulnerable plaque need to be looking like to change your management? Maybe we'll start with you, Joost, and then maybe Azeem, and then Valeria.
Yeah, what I think would make sense is to, and I think combined intravenous is the first in the right direction, is to really look into all these patients. So 50% of our ACS cases with multivessel disease, and we'll talk about that later today as well. But I think to me, the optimal patient population is the ACS population. Those are the highest risk patients. And then the particular non-culprit lesion. And if they have signs of plaque vulnerability, small MLAs, large plaque burdens, treat or not treat, I think that to me would be a very appealing design.
Azeem, you agree?
Yeah, that makes a lot of sense, Joost. I mean, go for the highest risk group where we know that there's an inflammatory component happening and there's multiple plaques that are potential to rupture. But I think what people really want is they want to know there's an easy way to identify a vulnerable plaque, and two, that intervention is going to impact hard endpoints, right? So that we can reduce patients from having an MI in the future from their non-stented arteries. I mean, to me, it's that kind of study. We're going to have to be able to show a real, absolute difference, an NNT that makes sense to treat patients and prevent MI. And I don't think, honestly, I think it's too simplistic to think that just a mechanical way of doing it is going to be enough. I think, what Joost is suggesting is right. I think it's going to be multifaceted. It's going to be drugs as well as potentially in some patients, some sort of mechanical factor in their artery. But I would love to think that this will be answered with drugs.
Valeria, what do you think? If you had to bet, are those trial designs make sense. I mean, there has to be some therapeutic actionable outcome that has changed. But what do you think?
Well, of course, a high risk group, and that would be the target. But ideally, what I would like to see is an imaging modality which combine, of course, the biology of the plaque, the anatomy of the plaque, and the morphology of the plaque. So in that way, we could be very accurate in identifying those plaque which are really at high risk. That's, of course, an ideal imaging modality. That it's not there. Of course, we don't have that, but that would make a great difference.
And Margaret, I'll give you the final word before we send it off. But for me, yeah, I have to say this session has been one where I looked at it, I was befuddled. What is there to be talking about? And then it was like super interesting. So, Margaret, what do you think? Where is this going, crystal ball?
Yeah, I agree. I think the Holy Grail has been able to identify the highest risk patients, both clinically and, as Valeria says, with the imaging, the patients with the highest risk patients with the highest risk lesions. And I think as the imaging field evolves, the problem with it is if you start a trial now, you'll probably have a better imaging modality by the time you get to the end of the trial that would identify even more specific high risk patients. So, but I think it's exciting, and I think particularly for me, the DCP approach seems very attractive.
Yeah, I think the therapeutics also evolve as well. Even for instance, prevent, you can argue very few people had PCSK9 inhibitors. And then once PCSK9 inhibitors come out, we'll have LP-A inhibitors next. And so you have to practice in a way that you're preventing events over the long term. But I think the biggest thing we need is proof of concept and proof of principle that we can identify these, they have a high rate of subsequent progression. And then if we treat them, we could potentially mitigate that. So thank you to all of you for an amazing discussion, great talks as well. And I think we have a look to the future for sure. So thanks to everybody, and thanks everybody for listening as well.